Our final podcast in the endocrine series will be on the adrenal glands. The adrenal glands are also known as the suprarenal glands. That's because of their location in relation to the kidneys. These are paired glands, and as you know from gross anatomy, they overlay the kidneys within the fascia around the kidneys. The blood supply to the adrenal glands. There are three suprarenal arteries that are derived from branches of the inferior phrenic artery, the abdominal aorta, and the renal arteries. And I think you can see that on the diagram. The adrenal gland is surrounded by a fairly thick connective tissue capsule. You can see a little bit of that here. It's divided into a cortex like this, and a cortex like this, and a medulla in the middle. The cortex are steroid secreting cells. The cortex is about 90% of the gland mass, and the cortex originates from the mesoderm. The medulla secretes catecholamines, epinephrine, norepinephrine. The cells in the medulla originate from the neural crest. Now I want to highlight for you, it is very important to understand that the cortex in the normal adrenal gland represents 90% of the mass of the gland, and that's clearly evident in this histological section. Oftentimes in adrenal pathologies, especially related to the medulla, the mass of the cortex will be much less, and I'll show you an example at the end where the mass of the medulla is much greater, and that's just an important point for you to understand pathologically. There's a central adrenomedullary vein, sometimes just called the central vein, which is a good anatomical and histologic landmark when you actually look at the adrenal gland. Now, although the cortex and medulla have different embryological origins, these regions are functionally related to each other. The adrenal cortex is controlled in part by secretion from the anterior pituitary. Here are just some histological views to help put some of the adrenal gland in perspective, and now we're going to make the slide much messier with some labels, but it's important that you understand the different histological layers in the adrenal gland. So here I'm showing you in the low power view the medulla, like that. So here's the medulla in a higher power view. A little bit of the connective tissue capsule up here. Zona glomerulosa, like this. The cells almost are in balls, almost reminiscent of what a glomerulus might look like. The zona fasciculata, like so. The zona fasciculata here, shown at the higher power. And then the zona reticularis. Here in the zona reticularis, the cells are more irregularly arranged, whereas in the zona fasciculata, they're more arranged as long cords. And then the cells in the adrenal medulla, typically large secretory endocrine cells. The blood supply, the superior, middle, and inferior suprarenal arteries, as we told you, supply the adrenal gland. There are capsular capillaries that supply the capsule itself. Then there are fenestrated cortical sinusoidal capillaries that supply the cortex, and these capillaries are going to drain into the fenestrated medullary sinusoidal capillaries. There's also medullary arterioles that transverse the cortex. They're within connective tissue trabeculae, and they bring arterial blood directly to the medullary capillary sinusoids. So the medulla in the adrenal has a dual blood supply. It gets arterial blood from the medullary arterioles and venous blood from the cortical sinusoidal capillaries that have already supplied the cortex. Now, all of the blood vessels in the adrenal are eventually going to coalesce to form the central adrenomedullary vein, or the so-called central vein. This diagram shows organization of cells within the adrenal gland in relation to the blood supply. So on the left is just the cartoon that I had on the last slide, and then on the right just showing some of the cells. So here you can see the zona glomerulosa. Cells in the zona glomerulosa secrete mineralocorticoids. Cells in the zona fasciculata secrete glucocorticoids and gonadocorticoids. Cells of the zona reticularis secrete glucocorticoids and gonatocorticoids. We'll talk about these in a little more detail in a few minutes. And then cells in the medulla will secrete either epinephrine or norepinephrine, and these are typical neurosecretory cells. Note that they have presynaptic nerve endings associated with them. As we've said, the adrenal cortex divided into 3 zones based on how the cells are arranged. These are all steroid-secreting cells, so they have numerous lipid droplets in their cytoplasm. They have abundant smooth ER and mitochondria with tubular cristae. Cells in the zona glomerulosa, this would be the narrow zone in the outer part of the cortex, perhaps 15% of the cortical volume. These cells secrete mineralocorticoids. Cells of the zona fasciculata, the thicker zone of the cortex, perhaps 80% of the cortical volume, these cells secrete primarily glucocorticoids. They do secrete some weak androgens, but primarily glucocorticoids. Cells in the zona reticularis, the inner zone, maybe 5 to 7% of the cortical volume, secrete weak androgens primarily. They do secrete some glucocorticoids, but primarily weak androgens. So there's a rubric that you can think of in relation to the function of the different regions of the cortex of the adrenal. You can think of the rubric SALT, sugar, sex. Zona glomerulosa secretes mineralocorticoids. Zona fasciculata secretes primarily glucocorticoids. Cells of the zona reticularis secrete primarily weak androgens. If we look at the layers in the adrenal cortex, the zona glomerulosa, the cells are grouped in an ovoid configuration. As we said, these cells produce mineralocorticoids, primarily aldosterone. This is synthesized in response to angiotensin. Aldosterone causes an increase in water and sodium reabsorption in the distal convoluted tubules and collecting ducts of the kidney, will result in increased blood volume and blood pressure. The secretion is controlled by adrenocortical trophic hormone, which is released from the anterior pituitary. Cells in the zona fasciculata are essentially arranged in radial columns. They are separated by capillaries. These cells produce primarily glucocorticoids, the main hormone being cortisol. This will increase metabolic availability of glucose and fatty acids to cells. Cortisol will also depress inflammatory reactions and will depress the immune system. Cortisol is also under the influence of secretion from the anterior pituitary, once again controlled by adrenocortical trophic hormone. Histologically, just to remind you again, the connective tissue capsule, the zona glomerulosa, the most peripheral layer, the cells in balls or clusters just beneath the connective tissue capsule, the zona fasciculata, the middle zone. The cells have many apparent lipid droplets, so the cytoplasm appears vacuolated. You'll often see lots of capillaries and maybe some of these medullary arterioles and the cortical sinusoids. Cells in the zona reticularis, they're organized in a loose meshwork of cells. These cells produce primarily weak androgens, the most prominent one DHEA. They also produce some glucocorticoids. Like the rest of the cells in the adrenal cortex, secretion is under the control of the anterior pituitary. Adrenocorticotrophic hormone released from the anterior pituitary influences these cells to secrete their hormones. This is just an ultrastructural view of some of the cells in the adrenal cortex. Here it's just showing a high-powered profile of what cells might look like from the zona fasciculata. So there's abundant smooth endoplasmic reticulum. There are mitochondria with so-called tubular cristae and abundant lipid droplets. The adrenal medulla is the central portion of the gland. The parenchymal cells are chromaffin cells. These are actually modified neurons that derive from the neural crest. They're arranged in clusters and cords. They're innervated by presynaptic neurons. It's a little bit difficult histologically to appreciate that innervation. The medulla also contains connective tissue, numerous sinusoidal capillaries. You can see some of the the capillaries in a profile like that, maybe something like that. There are myelinated nerves that are in the adrenal medulla. Again, those are difficult to appreciate histologically. There are also ganglion cells which are difficult to appreciate histologically. These ganglion cells extend axons to the adrenal cortex, perhaps to modulate the secretory activity of cells in the adrenal cortex. They also innervate blood vessels, and the ganglion cells extend processes outside the gland into the splanchnic nerves. The chromaffin cells are classic APU-D cells. These react with chromate salts. You get oxidation and polymerization of the catecholamines within the secretory vesicles, and that causes these chromaffin cells to take up a brownish color to the cytoplasm, and that's shown on the bottom image. And as we said, APUD defines a classic type of neuroendocrine cell. I think in other areas in the course we've talked about these cells as amine production, uptake, and decarboxylation cells. They are found throughout the GI tract. For example, there are APUD cells that are also part of the islet cells in the pancreas. Catecholamines are secreted by these chromaffin cells, and there are two types of chromaffin cells that are recognized histochemically based on the secretion of either epinephrine or norepinephrine. In the electron microscopic view, norepinephrine cells exhibit numerous vesicles with very electron dense cores. The epinephrine cells have cores that are less electron dense, and I think in these micrographs you can see that. Here are the very, very electron dense cores in the norepinephrine chromaffin cells, where the cores are a little bit less electron dense in the epinephrine secreting chromaffin cells. Approximately 80% of the catecholamine secretion is epinephrine. Glucocorticoids secreted in the cortex induce conversion of norepinephrine to epinephrine. The image on the bottom is just a histochemical stain for the enzyme phenylethanolamine N-methyltransferase, so-called PNMT, which is responsible for the conversion of norepinephrine to epinephrine. You're going to talk about the fight or flight response in physiology. The fight or flight response is related to catecholamine release. When catecholamines are released, this will stimulate glycogenolysis. That will release glucose to the bloodstream. You'll get an increase in blood pressure. You'll get dilation of the coronary vessels. There'll be vasodilation of vessels supplying skeletal muscle. There'll be vasoconstriction of the vessels that supply the skin and the gut. There'll be an increased heart rate and cardiac output, and there'll be an increase in rate and depth of breathing. Regulation of chromaffin cells, as we've said, these are modified post-ganglionic synaptic neurons, so there'll be release of epinephrine and norepinephrine under the control of the sympathetic nervous system, and this will stimulate the flight or fight response. An important clinical correlation in relation to the adrenal medulla would be Pheochromocytoma. These are tumors that are derived from chromaffin cells. You can see that on the CT scan here. These are usually associated with the adrenal medulla, but they can sometimes be located outside the adrenal medulla. They're usually benign tumors, but they produce excessive amounts of catecholamine, mostly norepinephrine. Thus, these tumors can precipitate almost life-threatening hypertension, cardiac arrhythmias, and anxiety. Now, the histology, this is where I want you to remember there's a much enlarged area of medulla in relation to the adrenal cortex. So where in the normal adrenal, the cortex might be almost 90% of the volume of the gland. In these pheochromocytomas, that might flip around, and it may be that the medulla may be the vast majority of the volume of the gland. The cells in the medulla are very highly vascular, and there's very bizarre looking nuclei in these pheochromocytomas. There's also a rule of 10 that pathologists look at with pheochromocytomas. It's worth you thinking about this as you go on to pathology. It turns out that 10% of the pheochromocytomas are extra-adrenal, and of those, 10% reside outside the abdomen. 10% of pheos occur in children. 10% might be multiple or bilateral, meaning you might find them in both adrenal glands. 10% are malignant. 10% have a strong genetic or familial tendency. 10% actually recur after surgical removal. 10% are found incidentally during unrelated imaging studies. So the rule of tens for pheochromocytomas is worth remembering.